It's really personal in terms of how a patient is going to experience this loss. But keep in mind that it's a very, very public loss.
Welcome to the Learn Skin podcast with me, Dr. Raja.
And me, Dr. Hadar, where we discuss all things skin.
Join us as we delve into the art and science of skin health in today's episode.
Hey, Raja, can you say the thing I told you to tell them?
Of course. We are board-certified dermatologists. This podcast is meant for educational and informational purposes only and is not considered medical advice, nor does it serve as a substitute for professional care by a doctor or other qualified medical professional. All opinions shared do not express the views of Learn Health, Inc. Let's get to the good stuff.
Hey, Raja, how are you today?
You know, I'm doing pretty well, but I feel like we have a couple of hairy topics to talk about today, huh?
Oh, absolutely. Thank you so much for that pun. I was thinking about it the whole week. Actually, we get so many patients in our clinics that have hair loss, specifically alopecia areata. There's a vast array of new treatments coming as we're discovering new therapies that can fend off the immune system that goes awry in some of these conditions, including alopecia areata. So we need someone to kind of take us through this forest of new therapies and old therapies and how they can work together. Oh, you catch my point. You get where I'm going with this. We need some help.
I think we need to get to the root of it, right, Hadar? I think that's the key here. And
at least to the outer root of it, at least.
Oh my God, this is getting out of control. We need to just move on to introducing our guest. I will say that our guest is Dr. Paradi Mirmirani. She is an expert when it comes to hair. I always enjoy all of her lectures when I go in there. I'm furiously taking notes, and she is an expert when it comes to alopecia areata. She's practicing at Kaiser Permanente Medical Center in Vallejo, California. She serves as the Assistant Chief of Dermatology, the Regional Director for Hair Disorders, the local research chair, and she's the regional co-lead for dermatology research. So she clearly gets what's going on in the clinic, also has a pulse on research. I can't think of anyone better than to have you on this program with us today, Paradi. So thanks for joining us.
Thank you so much for that welcome, Raja and Hadar. I was trying not to laugh too hard at all your hair puns, but I loved them. That's great. Thanks for having me today.
Yes,
it's a dad joke central here. Let's keep it real, for heaven's sake.
Exactly. And Paradi, you know, we have been talking about alopecia areata for generations and generations. And I thought maybe we can start by giving a brief overview of what are the current therapies that we offer our patients. And what is the gap? Why do we even need these new agents that feel coming through the market every Monday and Thursday?
Alopecia areata, like you said, it's been around for a long time. For those of us who went through residency quite a few years ago, it was a lot of oldies but goodies. It was a variety of treatments that we would use and variety of success. But it's really a new landscape out there now. We've got some treatments that I'm very excited about, work like gangbusters. And it really provides new treatment to patients who may have otherwise been left untreated or not had good success with other treatments, especially for those patients with more severe alopecia areata. And that's the Janus kinase inhibitors that hopefully everybody's heard about. Again, we've had a lot of success with these treatments. We still have new Janus kinase inhibitors that are coming out in clinical trials. So first generation's out there. We've got some data. Newer generation of the medication is coming out, hopefully safer, more effective. So that's really where a lot of the excitement has been generated. It's not often that you have a new medication for a disease that you've been treating that can sometimes be quite frustrating.
Yeah, I think you just nailed it right there, because we have so many diseases in dermatology where I feel like we're, after the just revolution in psoriasis, a lot of us are like, what's next? Which disease that has just been so challenging for people are we going to tackle next? And, we keep changing this microscope of research, and it's very exciting. And you talk about the frustration of treating this disease, and now with the Janus kinase inhibitors, maybe there's some new hope. Can you talk about what was the status of the treatments before? Where were we? What was the typical treatments that we had available, and how good were they?
Yeah, you're exactly right. I think it's kind of the way psoriasis was a few years ago, where these new treatments kept coming out. But, I think the thing I talk about in my lecture as well, that we have a number of different treatments, and it's not one treatment fits all. We need to take the patient's alopecia areata into consideration. How old are they? What are their other medical conditions? How extensive is their disease? What have they tried before? So you really want to personalize the treatment for that patient. And for patients with small areas of patchy alopecia areata on the scalp, sometimes no treatment is needed. Sometimes topical treatment you can get away with. Intralesional corticosteroids are still the most reliable treatment. You're not going to go to a Janus kinase inhibitor for small patchy areas of alopecia areata. Add to that a number of other topical treatments that are quite safe to use. So especially for children, even for adults with more extensive disease, I will start with other treatments, topical treatments, because hands down they're going to have the best safety profile. So things like short contact anthralin, squaric acid, or topical immunotherapy with squaric acid or difensiprone can be quite effective even for patients who have more extensive hair loss. And again, I love throwing everything together. So I often tell my patients, I like to give you a cocktail. Let's try the topical, the intralesional, and let's see where that gets us. And then if it's more extensive or if it doesn't respond, then that's when we're going to start talking about other options, including the Janus kinase inhibitors.
Paradi, I know you're talking about, treatments, but I just want to pause and say I have a couple patients that have really struggled just even, I didn't realize this was the patient experience. They told me that when they lost all their hair, everyone started treating them as if they were going through chemotherapy, and there was like a different way that they were treated. And in fact, one of them works at a med spa, and some of the patients that would come in would say things like, oh, how come you're working here? Like, you don't seem to fit the right mold of an employee that you should be working here. It's just these kind of microaggressions that our patients face, or just misconceptions that they face, that I can only think that's going to wear on your soul over time.
Oh, it's devastating. It's really devastating. Alopecia areata, much like psoriasis, as we were talking about before, it's really personal in terms of how a patient is going to experience this loss. But keep in mind that it's a very, very public loss. So everybody is able to see what you're going through. And that makes it that much harder often for patients. And there have been many studies looking at the impact on patient, on their mental health. And it's dramatic, it's significant. So anytime I see a patient, we spend time talking about what is this? This is an autoimmune condition. We talk about what it is, that the hair follicles are not destroyed. We talk about treatment, medical treatment, and then we spend time on mental health. And so that's such an important issue to talk about with patients. How are you handling this? How are your spirits holding up? Who are you talking to? What are the issues you have? And again, keep in mind, it's not just the patients who lose all of their hair. Sometimes it's, one patch, but it's in an area that, again, is very public. For men, for example, they define themselves by the big bushy beard, perhaps, and then they've got patches in it. That can really take a toll. So it's important to address that question anytime you talk to a patient. How is this affecting you? In what areas is this affecting you? And how can we address that? It's just as important to talk about that as it is talking about the medical aspects.
I'm listening to you and I'm thinking, my gosh, I kind of want to be your patient. So nice to have someone who actually is considerate of the entire person in front of them, right? Not just that patch of hair that is missing, but their entire
important.
Health.
Right.
How the disease is impacting you. And based on that, we'll try to tailor a cocktail to your need. It's almost like the bartender, right? Like, come, tell me your story. And
exactly right.
We'll figure out what cocktail would work for you tonight.
Yeah, and since we're all interested here in integrative dermatology, I have patients who have a lot of questions. Was it the vaccine I got? Was it the food that I ate? Was it the stress that I had? And we don't always have answers to those questions, but important to talk about all those other things that have an impact on your health. Make sure you're getting enough sleep. Make sure you're getting exercise. Make sure you're eating well. And that's, in some ways, just as important as any prescription you give them.
Yes, absolutely. And thank you for bringing up this question of why, because before we jump into the therapies and kind of linking to what Raja said before about psoriasis, I always thought that if we can just find what is the immune system responding to, maybe we can hit it with an antibody, because now the biologics therapies in psoriasis has definitely transformed that field and patients' lives have been completely turned for the better. And I was hoping or expecting that we will do the same in alopecia areata, and yet mechanistically, it seems like we're moving towards more small molecules, which are not as clean, if you will, as an antibody, both in the therapeutic effect. Sometimes it has a benefit, you're hitting more than one target, and sometimes it can be an issue with side effects. So maybe you can give us a comment kind of linking to the JAK inhibitors. Where are we on the etiology? What is that target that the immune system is trying to attack, the hair follicle?
Yeah, good question. $1 million question there. I don't think that in 2021 we still have a complete answer to that question, but that doesn't mean that we haven't identified some important targets. So, and I think we haven't identified B antigen because there isn't one. It's probably multifactorial. There's multiple hits that can potentially trigger alopecia areata. We've looked at the hair follicle itself. We looked at the pigment cells. Sometimes you lose the pigmented hairs first, so that's certainly an interesting antigen to have looked at. But as with any other autoimmune disorder, it's complex. If we put all of the autoimmune disorders together, we really haven't found a target for any one of them. So it's probably a complex constellation of autoimmune tendency along with various antigenic triggers, perfect storm that can lead to an attack on the hair follicle. So a lot of progress is being made, and the JAK inhibitors are a perfect example of this progress.
Yes.
We really were able to, meaning the dermatology community, but a lot of credit certainly goes to Dr. Angela Cristiano in Colombia, who lab identified the importance of the JAK inhibitors. And, it has, again, led to really important progress in therapeutics. But again, this is probably not the only target because not everybody responds 100%. We do have some treatment failures. So again, there's probably, like you said, it's not clean, and there will be more progress along the way. Again, we've got the alopecia areata treatment 1.0 and 2.0 and 3.0 probably coming.
Right.
But I like to tell my patients it's a much more targeted tool than things like prednisone that we used to use in the past. And we still use occasionally as well, but it's much more targeted in terms of the immune signals that are involved in alopecia areata. And I tell them it's a lot like we're cutting the phone cords so that the immune cells can't communicate with their friends and say, hey, come on over here, we're having a party. So even if you cut the phone cord, sometimes there's still other ways of communication. There's, there may be a text, there may be some signal that gets through, right? And so you do see these instances where we don't end up getting good treatment response, breakthrough hair loss. So I think those breakthroughs will be coming down the road soon.
Yeah, and I'm wondering how your Generation Z patients take that imagery, which I love, of a phone connection like that. They're like, what is that phone you're talking about?
Who does that anymore?
Yeah, no, exactly. But I think such a good example to give, I think, is very useful, breaking that communication line between the cells. Absolutely. And so speaking of that, maybe you can give us a brief overview of that promise that we're talking about for JAK inhibitors, why we think they're working. I know I've personally witnessed in clinical trials and obviously reading the literature, this transformative effect when it works. It's just incredible. And patients are, speaking of that burden that we described earlier, are completely transformed, both their outlook and their confidence. And it's just a pleasure to see. So where are we how far have we gone? What's on the market? What's not? What's coming down the pipeline? And before you answer that, I just want to tell our listeners, because you were mentioning your lecture, that's your brilliant lecture coming up in the Integrative Dermatology Symposium. That's going to happen in Sacramento. There's still a few seats left. So if you are listening to this, get online and register yourself. yourself. It's the end of October. If you can't get a seat in person, don't worry. There is a virtual meeting that you can join us as well and listen to the entire lineup of hair lectures that we have, which is spectacular, including a talk on platelet-rich plasma, and of course, our famous panels where we'll discuss how we actually treat patients in the real world. So with that in mind, Paradi, why don't you take us through an overview of the JAK inhibitors? How do you think about them? When do you use them? And when can others also use them?
Yeah, so thank you for that lead in and for drumming up interest in our hair panel. I think it will be fabulous. Thank you. So with the Janus kinase inhibitors, a lot of the questions that I get from my colleagues are, what would be the appropriate time to use them and who would I use them in? I still don't think of them as my first line treatments for alopecia areata. That's kind of, I'll put that out there. I still, even with rapidly progressive hair loss, I will still start with a dose of prednisone if it's rapidly extensive and heading towards totalis. We'll do a prednisone course. Topical immunotherapy we'll discuss. If patients have failed those kind of conventional treatments, if their hair loss has been progressive or long-standing and not responsive to treatment, and long-standing at least 6 months or more, and that's what the clinical trials are looking at in terms of criteria. So alopecia areata can come and go, so you don't want to hit it with your big guns until it's clear that it's here to stay or that it's not responding. So that I give to my colleagues as a helpful guide, that it's not your first line treatment. Use other things, consider other things. And then if you're stuck, then yes, a Janus kinase inhibitor may be the next step to take. Also keep in mind, we're still in the midst of doing a number of clinical trials. So clinical trials will be another good treatment option for our patients. If none of those are an option, the clinical trials are not an option, there are 3 Janus kinase inhibitors on the market currently that are FDA approved for other indications, but we do use them off-label. So tofacitinib, baricitinib, and ruxolitinib. And most people who treat patients with alopecia areata, they rely on tofacitinib. That's the one that's been used mostly. It probably has a fewer side effects. And we can use this. I think people are having more and more luck getting it approved by insurance. That's been one of the major hangups. The patients will often start reporting improvement with the Janus kinase inhibitors at about 3 months. And I wait at least 6 months to see a response before I say, well, they're not a responder. It's about 60 plus response rate for full regrowth. So those are the numbers that I give my patients. 3 months before we start seeing regrowth, and it's about 60 up to 70% of patients who will see really good regrowth. There's probably higher for some regrowth, but for full regrowth, cosmetically acceptable regrowth. And then the other thing that I talked about before is I use cocktails, I use combinations. So in some patients, if they're having some regrowth but not really good response, I may give them a burst of prednisone, or I may add topical minoxidil, oral minoxidil to their regimen to help move along the hair regrowth. And then as far as just things that you need to do to monitor the medication, essentially much like the medication monitoring that we do for our patients on biologics for psoriasis. So I make sure they get their vaccines, check them for hepatitis before they get started, check them for TB. And then the regular monitoring that I do is a CBC, lipids, and liver function. And I check it in the first month. If they're doing okay, then we can push that out to every 2 months or every 3 months. So that's kind of a big overview of the JAK inhibitors. The other thing, lastly, just to keep in mind is that response tends not to be durable. So let's say we put a patient on it, they do well, they start seeing regrowth. Okay, now when can I stop? You want to make sure they have that 100% regrowth. You probably want to go a few months, even up to a year after regrowth before considering decreasing the dose or stopping the dose. If they develop a patch here and there, you can inject it with cortisone, but then you know that their disease is still active and you don't want to stop the JAK inhibitor. So the end game is not totally clear. Clinical trials still trying to figure that out.
Paradi, I have a question regarding these JAK inhibitors. You know, you mentioned a little while ago, you were saying in the very beginning that if someone has rapidly progressive disease, you're probably going to reach for prednisone. Do you think that'll shift if there's an FDA approval that really pushes one of them to become more first line, just because we really don't have anything systemic, right? That's specifically FDA approved?
I don't think so, Raja, because there are patients who will respond to that burst of prednisone and then maybe have full regrowth. Or I have patients on my list who are interested in clinical trials, and when I call them back because they've had alopecia areata for 6 months, they say, "Oh, sorry, I've regrown." So if you put them on a JAK inhibitor from the get-go, you might end up committing someone to a medication they may not need to be on for long term. So I think it's important to get a sense of whether, again, in that first 6 months, things are, and it may be less than that, but I still don't know whether that will necessarily be my first line.
This brings up a really good point, because in the alternative complementary space, or I guess you could say integrative space now, there's always these other treatments that are pushed forward as potentially promising. But I guess the point you're making here is in early alopecia areata, you might just turn around anyway. So,
That's
having
right.
that control population.
Remission happens. Yeah.
Yeah, exactly. So having a control population is essential if we're going to do a really well-designed study.
Yeah, we had a patient in our clinical trial who regrew like gangbusters, and then surprised all of us when we found out she was on placebo. Yeah, so that happens.
Power of the mind, potentially.
Yes, absolutely. And I think you're highlighting the heterogeneity of the disease, kind of going back to understanding some of the basic mechanisms so we can understand how to attack it. And I guess what we're seeing is, even in the presence of these relatively efficacious therapies, or at least potentially efficacious therapies, we're still not clear who would be the best patient for these therapies when the time is right. So certainly, and I know I tell my patients a lot of time that, this thing can turn around by itself. We're going to start treating and see how you're doing, but keep in mind that, we may not need all of this. And it's a good thing to give them some hope as well. And it's nice, we're not lying to them. So it's nice to say that there are some people who just, like you mentioned, just out of the blue, they regrow and they don't need to see us anymore. So that'll be a great thing. Can you take us through a little bit of the side effects? Because I think there's a lot of concern on that aspect from people who treat patients that have alopecia areata. They're concerned about causing damage, or as we always say, we don't want the treatment to be worse than the disease. So what kind of adverse effect have you noticed in your practice?
Yeah, so I think that's super important to address, both for the patient, when this might be something that you would have them on longer term, and keeping in mind that some of the topical treatments, like topical immunotherapy, has maybe a 40 to 50% response rate. So if you can get away with something topical, then that should be first on your therapeutic ladder. But then if you are moving on to the JAK inhibitor, what are the side effects that you need to discuss with your patient? So it can affect levels of your blood count. So both red blood cells, white blood cells, can lower those. So that's why we monitor it. That can also lead to increased risk of infection, or cutting those phone cords. And sometimes you need to pick up the phone and say, hey, there's an infection happening. So upper respiratory infections are a concern. Potentially viral infections like shingles can be a concern, tuberculosis. And then there's that theoretical risk of malignancy. We haven't seen it in our patients, in our alopecia areata population, but anytime you're suppressing the immune system, that's a theoretical risk. So again, that's something that we discuss with the patients. It's very directed immune suppression, but theoretically, that's a long-term concern. And more the day-to-day things, it can sometimes make your acne flare. It can be associated with headaches sometimes. So don't be surprised if the patient starts asking you about their acne. But other than that, on a day-to-day basis, it's relatively easy to take.
That's wonderful to hear. And I cannot wait to hear more details and, of course, clinical pearls when we see each other in person, finally, in Sacramento in October, just around the corner. My gosh, seems like we've been waiting for this forever. So, and we'll meet again in Sacramento, right next door to Napa Valley on a glass of wine. I think it'll be great. So I can't wait. And thinking of the hair panel coming up, all the clinical pearls that we're going to hear and learn from experts such as yourself. I mean, it's just going to be great. So if you haven't registered yet, this is the time to do it right now. Don't wait anymore. Just point your browser to the Integrative Dermatology Symposium, click register, and before you know it, you'll be just a hair further from listening to us live. Thank you, Paradi, for your time, your expertise, and really contributing to transforming patient lives.
Thank you so much, Hadar and Raja. I appreciate you having me.
Hey, Raja, what are you doing this October 22nd through the 24th?
There's only one right answer to that question: the 4th Annual Integrative Dermatology Symposium.
Of course. Now, a question. Are you going to travel all the way to Sacramento, California to meet me in person, or are you going to join virtually in your pajamas?
Pajamas in person? Well, you might see me in pajamas at the Sheraton Grand in person in Sacramento, or maybe I'll be in a Jolly Folly costume. Who knows? But I'm excited to chair this hybrid, one-of-a-kind conference with you, Hadar.
Well, man, I do love this unique event our team just put together. This is an event that really takes an integrative approach to common patient questions, also an integrative approach to challenging dermatology diseases. We also are going to cover aesthetics and have practical takeaways to start using in the clinic right away, just when you come back. So, this is the kind of information I just can't find with any other meeting.
So true. And the good news is it's not just for us. It's for practitioners of all backgrounds, and everyone is welcome. Use our discount code IDS25 at checkout for 25% off registration. And you can find us at www.integrativedermatologysymposium.com. Come say hi and tag us on social if you'll be there. And our tag is @Integrative Derm Symposium.
We hope to see you there.